We need just to work on the dates for the next sessions, guys, for Dr. Silverman and for this series as well, Dr. Anderson.
Platform is open.
Okay, great. So we speak later about this, but we need the new dates and the topics. Okay, hi everybody. Welcome to Congenital Heart Academy. I'm very happy to have all of you with us today. I'm sure this is going to be an amazing session as usual. Please follow us on social media and subscribe to YouTube channel. Yesterday I was taking a look on the YouTube channel and I realized that we have almost 10,000 people there. So thank you very much for being with us. And I'm sure this is a great legacy that all the amazing speakers of Congenital Heart Academy are letting to the future generations of pediatric cardiologists, surgeons, and everybody that is related to congenital heart diseases. So if you didn't subscribe to the channel, please do so. And there we are going to find very nice sessions, including this one, if you want to check again. And if you want to send to your colleagues, if you find it's useful, please do so. And just a reminder that save the date for the World Congress of Pediatric Cardiology and Cardiac Surgery. We are working very hard on that. It's going to be an amazing meeting and it's going to be great to see all of you in person there. So it's going to be from 27th of August to 1st of September 2023 in Washington, DC. So please save the date. And we are working on new dates for this series and for Dr. Silverman's series as well. So we are going to let you know as soon as possible. So please check on our social media and for sure you're going to receive an email with the new dates. So now we are going to start with Dr. Anderson and Diane and Adrian and Justin with this amazing series today. Please don't forget to type all of your questions on the Q&A chat box. We're going to be happy to discuss them in the end. Now I'll find the video. Just a second, sorry guys. Sorry for the delay. It's my Zoom that is not picking up the right.
Somebody should launch the meeting.
No, it's me. Very good. I found it.
Well, good afternoon to you all, ladies and gentlemen. As you will see from the title of the presentation this afternoon, we're going to be discussing abnormal pulmonary veno-atrial connections. You'll remember that in our last session, we discussed systemic venous anomalies. And we emphasized at that time that if we were to appreciate normality, we needed to take note of atrial arrangement. And that is also the case today when we consider pulmonary veno-atrial anomalies. So this afternoon again, I'm going to be joined by Diane, who will be showing you lots of videos, by Justin, who is making his way at the Cleveland Clinic. He's going to share with you some of his computed tomographic presentations. So let's start off by emphasizing again the importance to take note of bronchopulmonary morphology. Because when the atrial appendages are lateralized, to the best of my knowledge, we've never seen the situation in which the veno-atrial connections are isomeric. If you look at it the other way round, the pulmonary veno-atrial connections, which are our topic for discussion this afternoon, are always anatomically normal when we have left isomerism. And that, of course, is because in the normal situation, the pulmonary veins connect to the atrium that has a morphologically left appendage. Contrariwise, if we have right isomerism, so that both atrial chambers have morphologically right appendages, then the veno-atrial connections are always going to be abnormal, even if they come back to the heart. So let's start off by looking at these situations. To do that, Diane is going to demonstrate to you hearts that have isomerism of the atrial appendages, left isomerism, right isomerism. She's going to emphasize these points of understanding veno-atrial connections in the setting of isomeric atrial appendages.
If we look at this specimen with isomerism of the left atrial appendages from the posterior aspect, we can see that there are bilateral long bronchuses, so morphologically left bronchuses. The inferior cable vein joins the left-sided morphologically left atrium, and here we can nicely see the right pulmonary veins clearly joining the right-sided morphologically left atrium and the left pulmonary veins joining the left-sided morphologically left atrium. Turning the specimen over, we can see the tubular appendage representative of the right-sided morphologically left atrium and its appendage. And here we can see the pulmonary veins draining directly into the roof of this right-sided morphologically left atrium, so that this pulmonary venous drainage is essentially normal in this specimen with bilaterally morphologically left atrial appendages as the pulmonary veins drain to a morphologically left atrium. So here's our left-sided tubular appendage representative of a morphologically left atrium. And here we see the pulmonary veins draining directly into the roof of this left-sided morphologically left atrium. And there we can see the coronary sinus also present within this left-sided morphologically left atrium. We're looking at this very interesting case of isomerism of the right atrial appendages from behind. And what makes it so interesting is that the bronchioanatomy is of the total opposite morphology from the atrial morphology. So here we have bilateral long bronchuses that are hyparterial. So bilaterally morphologically left bronchuses with bilateral bilobed lungs. The inferior cable vein is joining the right-sided morphologically right atrium just to the right of the midline. And here you can see the right and the left pulmonary veins draining in a somewhat more lateralized fashion rather than in the midline. This is the best example of a case of isomerism of the right atrial appendages where the pulmonary veins are somewhat lateralized. The right-sided morphologically right atrial appendage is easily appreciated here. And this specimen was sectioned in a somewhat incomplete 4-chamber plane. So when I open up the atriums, we can clearly see that there are pectinate muscles surrounding both atrioventricular junctions. This specimen did have a common atrioventricular junction. Here's our common atrioventricular valve with the inferior bridging leaflet crossing the crest of the ventricular septum. Looking inside of both of the atriums, we can see the right-sided terminal crest and the terminal crest associated with the left-sided morphologically right atrium. The inferior cable vein is draining here slightly more towards the right terminal crest. And if we stretch the atriums, you can see all 4 of those pulmonary veins draining to the left of the midline and to the right of the midline, so that all of these venous structures are draining into a somewhat common venous sinus in between both of the terminal crests.
So now we've made the point that we need to, first of all, determine atrial arrangement before we can settle upon the fact that there can be normal veno-atrial connections. And let me emphasize again that this afternoon, we're discussing the connections to the morphologically left atrium. So the normal arrangement is that the 4 pulmonary veins, 2 on each side, connect into the atrial roof. But we also need to take account of the remainder of the morphology of the left atrium. And of course, the thing that makes that chamber morphologically left is the appendage. And then the morphologically left atrium has a vestibule. And another of the features of its morphologically leftness is that the pectinate muscles do not extend round that vestibule as they do in the morphologically right appendage. We can look at the septum, and that has features that tell us that it is morphologically left, because we see the horns of the flap valve connecting on the left side of the septal structures. And then the other major feature of the morphologically left atrium, which is lacking in the morphologically right atrium, is the presence of a very large body. So now we're going to look at those normal features. And this time we're going to see them both in specimens, Diane demonstrating that to you, and then Justin demonstrating this anatomy using his computed tomographic data sets.
We're looking at the posterior lateral aspect of a normal heart with the lungs attached. And here is our tubular appendage with its narrow junction to the atrial vestibule, characteristic of a morphologically left atrial appendage. The pulmonary veins on the left have already been opened into the roof of the left atrium, so you can see how they join nicely. The right pulmonary veins are a bit more difficult to see from the inside of the atrium. So if we tilt the specimen up, we can see the inferior caval vein here joining the floor of the right atrium. This is the oblique pericardial sinus. So you can see the left lower pulmonary vein and the right lower pulmonary veins joining this morphologically left atrium in this normal heart. If I place my probe in the left atrium, we can then see the right middle and the right upper pulmonary veins also joining the roof of this morphologically left atrium. The atrial appendage has this narrow junction with the atrial chamber, and the vestibule is entirely smooth in the normal heart. There's the coronary sinus at the left atrioventricular junction. And here we see the left side of the flap valve or the atrial septum, giving us its usual horseshoe appearance where the horns of the flap valve become adherent to the superior interatrial fold. Here again, we see nicely the opened left pulmonary veins joining the roof of this normal morphologically left atrium. And there are the right pulmonary veins also joining the roof of this left atrium.
In this normal computed tomographic data set, we're viewing directly anterior at a fluoroscopic-like image, looking at the cardiac silhouette. We'll bring the pulmonary veins into view, colored in red, as they drain into the back side of the left atrium. We'll bring the rest of the heart into view with the right side of the heart in purple, the superior caval vein draining into the right atrium with its right atrial appendage, the right ventricle, the pulmonary trunk, and its left and right pulmonary arteries. In orange, the left atrium with its left atrial appendage, the left ventricle, the aortic root. We can see the right coronary artery and the left main with its left anterior descending, coursing into this anterior interventricular groove, and the ascending aorta. And again, the pulmonary veins in red as they drain into the posterior aspect of the left atrium. Turning leftward into the long axis of the left atrial appendage, we can appreciate that the left upper pulmonary vein drains just posterior to the base of the left atrial appendage and coursing inferior to the left pulmonary artery. We'll continue to rotate so we view directly the posterior aspect of the left atrium with the left upper pulmonary vein, left lower, right upper, and right lower pulmonary vein, with the right middle joining the right upper to drain together into the backside of the left atrium. Less commonly, the right middle can drain by itself as a fifth pulmonary vein into the left atrium, a normal variation. And if we bring the descending aorta into view, we can appreciate the close relationship to the left lower pulmonary vein. Often the left lower pulmonary vein in an axial view will have a smaller dimension than its superior-inferior axis, related to its close relationship to the descending aorta. And in various pathology, the left lower pulmonary vein can be compressed by the descending aorta. We also, seeing this posterior view, can appreciate, just like the left upper pulmonary vein drains inferior to the left pulmonary artery, the right upper pulmonary vein drains inferior to the right pulmonary artery. Then we'll come around all the way anterior again, and we'll switch to a virtual dissection image. We'll cut anteriorly first into the right side of the heart, the right atrium and right ventricle and pulmonary trunk, and then into the left side of the heart with the left ventricle and the aortic root. And then further posterior, we get to the most posterior structure, the left atrium, and here the mitral valve. And so the left atrium has a much larger smooth body than the right atrium, leading up to the smooth vestibule down to the mitral valve. Here's the base of the left atrial appendage with the pectinate muscle contained within this small finger-like appendage. And over on this side is the septal component of the left atrium, with its 4 pulmonary veins draining into the back side of the left atrium. And as we tip it to view the left side of pulmonary veins, we see the left upper and left lower pulmonary veins. And then viewing rightward, we see the right upper coursing under the right pulmonary artery and the right lower pulmonary vein. And then we'll switch into a 2-chamber view, viewing the left-sided pulmonary veins and how they relate to the left atrial appendage. Seeing this left upper pulmonary vein coming in just behind the base of the left atrial appendage with this ridge between them. This ridge can be prominent sometimes and historically has been mistaken for a thrombus, leading patients to inappropriately be put on blood thinner or Coumadin. So the historical name is Coumadin's ridge. And then just below that being the left lower pulmonary vein.
So now we know what we need to look for. We've seen the influence of isomeric atrial appendages. We know what is the anatomy of the normal morphologically left atrium. So to put things into context, I'm going to show you now how the knowledge of development permits us to understand what's going on when the veno-atrial connections are abnormal. And I'm going to illustrate this to you in the setting of murine development. So this is a scanning electron micrograph of the primary heart tube in the developing mouse. You see it's at an early stage of murine development. E is embryonic day, so we're halfway through the 9th day of development. At this early stage, the mouse has no more than 9 somites. It's a scanning electron micrograph. It was made by my very good friend and colleague, Nigel Brown. We're looking at it from the front. Nigel has cut away the pericardium so that you can see that at this early stage, essentially we have a straight heart tube. But within the straight heart tube, we can see the atrial component. And what I'm going to show you is that I'm going to cut away the ventricular component, the larger part of the ventricular component at this stage is going to be the morphologically left ventricle. But I want to show you what it looks like at this early stage in terms of the way that the heart tube is connected to the pharyngeal mesenchyme. Because the lungs are developing within the pharyngeal mesenchyme behind the primary heart tube. So what we've done is we've cut away the ventricular loop, and then Nigel has turned this particular data set so that we can look into the atrial component of the heart, as it were, from the aspect of the ventricles. So that is how we're going to look down into the atrial component of the developing heart. So this is what it looks like. We've tilted the data set forward, so the spine is now to the top. And what you are seeing here is the gut. And in front of the gut, we can see that the walls of the atrial component reflect back into the pharyngeal mesenchyme. And we call this the dorsal mesocardium. You can also think of it as the heart stalk, because this is the area in which the walls of the developing heart are continuous with the walls of the pharyngeal mesenchyme. And this is the area through which the pulmonary vein eventually will make its connection into the atrial component of the developing heart. But you're looking at the bottom of the atrial chamber at this stage, and you can see the systemic venous tributaries. So that, to your left hand, is the opening of the right sinus horn. To your right side, you see the opening of the left sinus horn. And already you will see that the left sinus horn is smaller in its dimensions than is the right sinus horn. And that is because there is a shift of the systemic venous components, tributaries, so that they open primarily into the right side of the body of the developing atrium. And it's only when these systemic venous tributaries have shifted to the right that it's possible for the atrial septum to grow so as to leave the systemic veins opening to the right side and the pulmonary vein opening to the left side. So the essential part of development is this rightward shift of all the systemic venous tributaries. And here now we're looking at another mouse heart. This time we've taken a 4-chamber cut through the atrioventricular junction, and you're looking at the back of the atrial chambers. You see we've gone 2 days forward. We're halfway through the 11th day now. And now to your left hand, you are looking at the back wall of the developing morphologically right atrium. To your right hand, you're looking at the smooth body, the larger part of the body of the atrium, which now is part of what will become the morphologically left atrium. And now you can see that all those systemic venous tributaries have shifted rightwards so that they're opening to the right side. And now they are guarded by the venous valves. Now there in the back of the heart, you can see these two bulges, and they mark the location of that body stalk or the dorsal mesocardium. And now at this stage, the pulmonary vein has canalized and it is opening through these ridges, mark the site of the dorsal mesocardium, so that it can empty into the left side of the developing atrial chamber. And there is the opening of the pulmonary vein between those ridges. You can't see it terribly well in this scanning electron micrograph, but I can illustrate the comparable situation to you in these serial histologic sections. Now, these were made by my colleagues in the University of Amsterdam quite some time ago now, Alexander Caesarov and Toon Moorman. And they were able to cut serial sections through the developing heart at the similar stage that I've just shown you in that mouse arrangement. And this is Carnegie stage 14. This is the end of the 5th week of human development. And they've colored the walls so as to show you the gene NKX2.5. And we know that that gene is showing us ordinary working myocardium. And you can see there the opening of what will become the superior caval vein. To the other side, you can see the walls of the left sinus horn. And the key point here is that the walls of the venous structures at this time are not showing this marker NKX2.5. So the walls of the systemic venous sinus are negative. The walls of the atrial chambers are positive. And there, between those two ridges, as you saw them in the murine heart, you can see what will be the opening of the pulmonary vein. Now, the beautiful thing that my colleagues from Amsterdam were able to do is they were able to take the next section to this in the series of the serial sections taken through this human embryo. Here you see it. And they stained that with another gene, TBX18. And TBX18 is marking the myocardium of the systemic venous sinus. And there you see again the wall of the cavity rather of the right sinus horn. there is the cavity of the left sinus horn. And this time, the walls of the systemic venous tributaries are positive, but the opening of the pulmonary vein is negative. Why is this important? Because there has been controversy as to whether the pulmonary vein opens from the systemic venous sinus. And in fact, these serial sections show you the opening of the pulmonary vein has nothing to do with the systemic venous sinus. The pulmonary vein canalizes in the middle of the pharyngeal mesenchyme. It opens through the body stalk, and it does not open into the developing heart until after the tributaries of the systemic venous sinus has shifted to the right so that they open into the morphologically right atrium. And here we can see the situation in a long axis section. This is the equivalent to the parasternal long axis section. So what you are seeing there is the body of the left atrium, left ventricle. There is the atrioventricular canal. In the atrioventricular canal, you can see the atrioventricular cushions. And this shows you now that opening of the pulmonary vein. There it is, directly on top of the left sinus horn. It is opening very close to the atrioventricular junction, and it is opening through the body stalk, the dorsal mesocardium. It has nothing to do in normal development with the systemic venous tributaries. And we can see it again in this reconstruction. It's one of the reconstructions that I've shown you many times, made by Professor Wout Lammers, Dr. Jill Hickspoors, University of Maastricht. This time I'm showing it you from behind. So there you see the left sinus horn, which has now been incorporated in the left atrioventricular junction. We discussed that on the previous occasion when we were considering systemic venous anomalies. And there in green, you see the opening of the pulmonary vein. And what you are seeing there in pinky purple is that area surrounding the dorsal mesocardium. And what is particularly important is this major right ridge of the dorsal mesocardium, which has expanded to become the vestibular spine. And then if you look very carefully there, you can see in green the primary septum. And the primary septum has grown in such a way to put the pulmonary vein into the left atrium, guided by the vestibular spine. And I can show you then that the situation in which the pulmonary veins gain their connection to the atrial roof does not happen until very much later. So here we are. Now we're in the 7th week of development, and it is only at this stage that the pulmonary veins are incorporated into the roof of the developing left atrium. So there you see them. They've moved from that arrangement close to the atrioventricular junction. They have been cannibalized to form the roof of the left atrium. There is the body of the left atrium. See the left superior caval vein still at the back. And only at this stage, as the pulmonary veins reach the atrial roof, do we see the infolding that forms the superior rim of the oval foramen. So as they develop, the pulmonary veins have nothing to do with the systemic venous sinus. They canalize within the pharyngeal mesenchyme, and then they migrate to form the roof of the left atrium with ongoing development. But we also know that there are collateral channels present between those pulmonary veins and those systemic venous tributaries. And it is the presence of those collateral channels that produce the anomalous pulmonary venous connections. But to understand that, we also need to distinguish between anomalous connections and anomalous drainage, because we also know that the veins can be normally connected but still drain anomalously, simply because of the presence of those collateral channels that persist between the pulmonary veins and the systemic veins. And the classical example of that is the so-called levoatrial cardinal vein. And that is a collateral channel between the pulmonary veins when they are normally connected and any of those systemic venous channels. A variation on that is fenestration of the coronary sinus. That could be a simple window. I've seen a case very recently that could arguably be a levoatrial cardinal vein. And it is the connections between these two that show us how these windows can develop between coronary sinus and the cavity of the left atrium, because in normal development, as we have discussed, coronary sinus and the left atrium each have their own walls. And it is collateral channels between the two that produce the situation where the pulmonary veins can be normally connected to the left atrium, yet still drain anomalously to a systemic venous site. But what we are concerned today particularly is the connections. And it is those connections, those anomalous connections, on which we are going to concentrate. And the key here, as you've seen in the pictures I showed you of the developing processes, those normal connections are sandwiched between the systemic venous connections, the superior cable vein, the inferior cable vein to the right atrium, the left superior cable vein also eventually draining into the right atrium, but only having come through the left atrioventricular junction. And those pulmonary veins are sandwiched between the derivatives of the right sinus horn, the derivatives of the left sinus horn. But what happens when they drain anomalously? So to understand anomalously pulmonary veins, we need to look at the extent of anomalous connections. But in the extreme form, they are connected in totally anomalous fashion. And we have that when all of the lungs, all of the veins from all of the lungs drain anomalously. The lesser point is when only one of the lungs drains anomalously. And then even less, we can have partially anomalous connection, and that is when part of one lung drains anomalously. Then we can have mixed anomalous connection, which is any combination of the above. So when we are discussing anomalous connections, we start off by saying how many of the pulmonary veins drain or connect anomalously, but then to where do they connect? And this perhaps is the key, the site of anomalous connection. And in the majority of cases, they drain in supradiaphragmatic fashion, and they can drain to the superior cable vein. They can drain to the azygos vein, which in turn then drains into the superior cable vein, or they can drain to the coronary sinus. And all of these are draining in supradiaphragmatic fashion. If the pulmonary veins come directly back to the atrial chambers, however, not through the coronary sinus, then we should always be considering the presence of right isomerism. And then in the minority of cases, they can drain below the diaphragm. In almost all situations, this is to the portal venous system, on occasion, directly to the inferior cable vein. So let's begin to take that apart, and let's look at the arrangements that we find. But let's also not forget that the pulmonary veins can drain in partially anomalous fashion. And here we have important associations. The scimitar syndrome is perhaps the best form in which we have partially anomalous pulmonary venous connection. And there we can have sequestration of lobes, anomalous arterial supply. The other arrangement in which we know now an anomalous venous connection is key, sinus venosus interatrial communication. They're usually to the superior cable vein, on occasion to the inferior cable vein. And this, if extreme, can permit those systemic veins to drain directly into the left atrium. The key to understanding the sinus venosus communication, however, is that the rims of the oval fossa must be intact and the connection must be outside the oval fossa. It is a veno-venous malformation. So let's look at these particular features. And now we're going to ask Diane to show us scimitar syndrome, with partially anomalous connection to the superior cable vein and then a superior sinus venosus defect.
This specimen has partial anomalous pulmonary venous return associated with scimitar syndrome. The heart is actually quite large in this case. Here is the superior cable vein, the morphologically right atrium in this specimen with usual atrial arrangement. And here is the partial anomalous pulmonary venous structure that has this curved appearance similar to a scimitar. This vein was actually returning to the inferior cable vein, and the attachment here was cut during dissection. So that is the area where it returned to the inferior cable vein. And you can see the scimitar shape along the pleural surface of this partial anomalous pulmonary venous return on the right. This is a portion of diaphragm, and you can see the anomalous pulmonary artery that extended to drain into the descending aorta. And again, this was cut during dissection, but you can see clinically that that artery had a few coils placed to occlude it. So again, this partial anomalous venous structure along the superficial surface of the right lung, anomalously draining into the inferior cable vein and with that scimitar shape. We're looking at the right superior cable atrial junction in this specimen that has isomerism of the left atrial appendages. It also has partial anomalous pulmonary venous return of the right upper pulmonary vein to the superior cable vein. Here is the azygos vein where it joins the superior cable vein, and you'll note that it is quite large, as this specimen also had azygos continuation of the inferior cable vein. But just inferior to the junction of the azygos vein with the superior cable vein, you can see that partial anomalous pulmonary venous return of the right upper pulmonary vein to the superior cable vein. We're looking at the right-sided morphologically right atrium in this specimen with usual atrial arrangement. And here is the superior cable vein joining the roof of the atrium. Looking in to the atrium, we can see that the superior cable vein is associated with a sinus venosus defect, so that there is a systemic connection with the left atrium, and the superior cable vein overrides this defect. So you can see that it is partially committed to the left atrium and partially committed to the right atrium. Here, draining into the superior cable vein are the right upper and right middle pulmonary veins, so that they still maintain their connection with the left atrium, but are joining the superior cable vein. With sinus venosus defects, they typically occur in association with the superior cable vein, and in this case, the rim of the oval fossa must be intact, as we see here, so that there is a conduit of fibrofatty tissue or that interatrial fold that extends between the superior sinus venosus defect and the true atrial septum.
So we've looked at partially anomalous venous connections in the setting of these associated lesions. Let's now get into totally anomalous pulmonary venous connection. And we're going to start by looking at the supracardiac connection. And in the majority of cases with supracardiac connection, the so-called vertebral vein ascends through the paravertebral gutter, and then it drains via the brachiocephalic vein to the superior cable vein. On occasion, it can drain beneath the heart, and then it comes up through the paravertebral gutter. But to start off, let's ask Diane to show us the typical example in which the vertical vein is left-sided and it ascends to join the brachiocephalic vein.
This specimen has isomerism of the right atrial appendages and supracardiac total anomalous pulmonary venous connection. The apex of this heart was pointing to the right. And here you can see the left-sided morphologically right atrial appendage with the superior cable vein joining its roof on the left. If I lift the heart upwards, we can see the left and the right pulmonary veins joining in this confluence posterior to the heart with a vertical vein extending between the bronchial tree and the pulmonary artery bifurcation upwards to join the brachiocephalic vein, where the pulmonary venous drainage then would extend into the left-sided superior cable vein and the left-sided morphologically right atrium.
Now, we don't have an example to show you through a video in which we have the connection through the azygous vein, but this is the nicest example that I got, showing it to you in a still image. This, in fact, is from an individual who had isomerism of the right atrial appendages. We've reflected the heart itself using the so-called Tausig maneuver. So you're looking at the back wall of the pericardial area. And there you see the left veins. And what you are seeing is that the left veins are turning underneath the heart and they are moving from left to right. So first we have a horizontal channel and it picks up the right lower veins. And oftentimes the ascending channel, which is now in the right paravertebral gutter, is within the parenchyma of the right lung. And it's sometimes called a wandering pulmonary vein. But here it is ascending up through the right paravertebral gutter, and then it's picking up the right upper veins, and it's terminating in the azygous vein, and then entering the superior cable vein. So this is supracardiac connection, but with a right-sided vertical vein. There it is, entering the azygous vein. So let's move on and let's look at the other form of supracardiac connection, and that is the cardiac connection. Now, I said this can be directly to the right-sided atrium. This is normal when we have isomeric left appendages, and Diane has already shown you that in our opening videos. We also have this frequently with isomeric right appendages, but then it is anatomically abnormal because those pulmonary veins are entering a morphologically right an atrial chamber with a morphologically right appendage. And you've also seen that. It is exceedingly rare with usual arrangement. And for myself, I can't recall having seen one. We don't have one to show you today. So what we're going to concentrate upon is the connection directly to the right atrium through the left superior cable vein. And it is that drainage through the coronary sinus, which of course is the derivative of the left superior cable vein, that Diane is now going to show you.
This patient had multiple congenital anomalies, both cardiac and non-cardiac. There was usual atrial arrangement, and intracardiac malformations included an atrioventricular septal defect and total anomalous pulmonary venous connection to the coronary sinus. If we look into the right atrium, we can see the superior cable vein joining its roof and the inferior cable vein its floor. There's the eustachian valve. And here we see our common atrioventricular junction with the leading edge of the atrial septum here and the crest of the ventricular septum here. This is a well-formed oval fossa with an intact flap valve, and here is the coronary sinus. The right and left pulmonary veins drain to the coronary sinus. There are the right pulmonary veins, so that the upper and lower veins join in a confluence prior to joining or draining to the coronary sinus, and the left pulmonary veins also extend posterior to the left atrial roof to drain into the coronary sinus. The same arrangement is seen here, where the upper and lower veins join in a confluence prior to extending to the coronary sinus. If I flip the specimen over, we can assess this from the posterior aspect. You'll note that this patient had esophageal atresia and a tracheoesophageal fistula with the esophagus arising from the carina. And if I pull the esophagus out of the way, there we can see the left pulmonary veins extending posterior to the left and right atriums to drain into the coronary sinus, along with the right pulmonary veins draining as well to the coronary sinus.
So now we've seen the variants of supradiaphragmatic connection to the superior cable vein, left superior cable vein, rarely directly to the atrium. Now let's look at infracardiac and infradiaphragmatic connection. And as I say, this is usually to the portal venous system. And that is important because then for the blood to get back to the heart, it has to pass through the liver, through that portal venous system to enter the inferior cable vein. And that will produce obstruction when the venous duct closes, meaning that then the portal, the circulation has to go through those hepatic sinusoids. And in my experience, again, it is very rare to find infradiaphragmatic connection directly to the inferior cable vein. So let's look at these arrangements. First of all, with Diane showing you a video in specimens, and then Justin showing you how well you can see these arrangements these days using computed tomography.
As you can see, the lungs and the liver remain attached to this heart that has usual atrial arrangement and concordant atrioventricular and ventricular arterial connections. Pulling the apex of the heart rightward, we can see the tubular morphologically left atrial appendage, and that there is no connection between the pulmonary veins and the roof of the left atrium. This patient has total anomalous pulmonary venous drainage that extends below the diaphragm or infradiaphragmatic. You can see the left upper and left lower pulmonary veins, and there is a solitary right pulmonary vein that joins this confluence posterior to the heart, and it extends below the diaphragm. This pulmonary venous confluence is unobstructed along its length and drains into the portal system.
This is a CT from an infant with infradiaphragmatic total anomalous pulmonary venous connections. This is a virtual dissection looking at the chest and the abdomen directly anterior, and we'll start to dissect into the body posteriorly. So we start to appreciate the liver with the umbilical catheter coming up the umbilical vein, and we can follow that into the inferior cable vein and into the right atrium here. And then looking back at the posterior aspect behind the left atrium, we see all four pulmonary veins coming together into this inferiorly directed vertical vein, which courses down to the liver into the portal system, narrowing down in the area of obstruction before it drains into the portal system and then communicating with the inferior cable vein. And we'll change this to an endocast image looking at the blood-filled pulmonary veins in red, all four coming together posterior to the left atrium, and then draining down this vertical vein into the portal system colored in purple, where it communicates with the inferior cable vein. So then I'll rotate this leftward so we can better appreciate this vertical vein and where it's coming into that area of obstruction of that portal vein before draining into the inferior cable vein. And then coming around all the way posterior and we can see how this pulmonary venous confluence is directly behind the posterior aspect of the left atrium. And without careful interrogation, one could be fooled if they see this flow behind the left atrium and potentially miss anomalous pulmonary venous connections. But there's no connection of these veins to the left atrium, instead coursing down this vertical vein into the portal system.
So I've already introduced you to the notion that we can have obstructed pulmonary venous connection. And we've emphasized that always when we have drainage in infradiaphragmatic fashion via the portal system, that this will become obstructed subsequent to closure of the venous duct. But we can also have obstruction in the other variants, and that's also important for you to recognize. When we have drainage via the coronary sinus or the left superior caval vein, then obstruction is rare, but we can find it produced by a Pavesian valve. What we don't know is more common is when we have obstructed drainage with supracardiac connection, and this, of course, is the bronchopulmonary vice. So this is what the bronchopulmonary vice looks like when we see it in diaphragmatic form. There I'm showing you pulmonary artery, and there you see the bronchus. And the essence of the bronchopulmonary vice is that the anomalous pulmonary venous channel, instead of passing outside the artery or the bronchus, is gripped between them. And there is the vice. It is the grip between the pulmonary artery and the bronchus. So now let's look at an example of the bronchopulmonary vice as demonstrated to you by Diane in one of her beautiful specimens.
This heart was normal aside from its total anomalous pulmonary venous connection, which was supracardiac. You can see the superior caval vein joining this very dilated right atrium. This is the left brachiocephalic vein, and here is our vertical vein that is draining the pulmonary venous blood. This vertical vein is extending between the aortic arch and the pulmonary bifurcation of the right and left pulmonary arteries, as well as in between the pulmonary arteries and the bronchial tree. So here you can see this constriction as opposed to this very dilated portion extending up to the brachiocephalic vein, where this vein extended in between the arteries and the bronchial tree is creating a bronchopulmonary vice or a stenotic segment. If I lift the heart upwards, we can then see the pulmonary venous confluence posterior to the heart, where we have the right and the left pulmonary veins joining this vertical vein that extends between the bifurcation of the pulmonary arteries, the aortic arch, and the bronchial tree. And this is the area where that vein becomes constricted at that bronchopulmonary vice.
So I've already told you, we can have these various forms of connection, supracardiac, to the heart itself, infracardiac. They can all come together when we have mixed totally anomalous connection, because those pulmonary veins, as you are all well aware, do not always drain to the same site, and they can connect in various patterns. So just as an example, we're now going to ask Diane to show us a specimen illustrating the features of mixed, totally anomalous pulmonary venous connection.
This specimen has both the lungs and the liver attached and has isomerism of the right atrial appendages. You can already see that the liver is quite symmetric. The inferior caval vein was left-sided, and these are hepatic veins draining into the right-sided, morphologically right atrium. The specimen also has mixed total anomalous pulmonary venous connection with the pulmonary veins from the left lung, joining a vertical vein, draining into the brachiocephalic vein, and then into the right-sided superior cable vein, so that the left pulmonary venous drainage is supracardiac. The right pulmonary venous drainage is infracardiac, as the upper and lower right pulmonary veins join a confluence that extends below the diaphragm. This infradiaphragmatic right-sided pulmonary venous drainage actually extends to drain into some of the gastric veins, and it becomes quite stenotic as it extends towards the lesser curvature of the stomach. And here you can see that left-sided inferior cable vein.
So we've looked at partially anomalous connection in the setting of associated lesions. We've looked at totally anomalous pulmonary venous connection. We also need to recognize, however, that the pulmonary veins can be abnormal when they connect to the morphologically left atrium. And this is the worrying situation of pulmonary venous stenosis. In fact, we know that pulmonary venous stenosis carries with it a very bad prognosis. And that reflects the anatomy itself. It can be tubular over a significant distance of the pulmonary veins. It can be waist-like, but irrespective of its morphology, it is bad news, and it's very difficult to treat. And in extreme cases, we can even have atresia of the pulmonary venous connection. So let's now look at what it looks like in the specimens. Again, we're going to ask Diane to show us the morphologic features of pulmonary venous stenosis.
If we look at the posterior aspect of the heart and lungs, here we can see the left main bronchus and the right main bronchus, and these very dilated pulmonary veins. The right pulmonary veins, in part, are joining very close and across the midline to where the left pulmonary veins are joining the left atrium. You can also appreciate how dilated these veins are, lifting up the right lower lobe. The remainder of the right pulmonary venous drainage is here, far to the right side of the left atrial roof. Where the pulmonary veins are joining the atrial roof, they are extremely stenotic, with the left pulmonary veins represented only by nearly a pinhole, and the right lower pulmonary veins immediately adjacent to them. Looking a little closer, here we can see the very small junction of the right upper pulmonary veins with the left atrial roof. So extremely stenotic junction of all of the pulmonary veins with the roof of the left atrium, and the right lower pulmonary veins extending across the midline to join nearly at the same site of the left pulmonary veins.
So there we have it. What we've tried to show you today is that, as with systemic venous anomalies, to understand what's going on, you need, first of all, to understand normal anatomy. You need to take note of the associated lesions. And in this regard, as with the anomalous systemic venous connections, distinction between isomeric, usual, or mirror imaged atrial arrangement is the key to full understanding. And whenever you have direct atrial connection or bilateral connections, you should always be suspecting isomerism of the atrial appendages. What I hope we've shown you is now, with an appreciation of development, you can understand what's going on, although today we've seen relatively little in terms of computed tomography, more and more we're going to be using computed tomography to demonstrate all of this anatomy, because now using that technique, using living anatomy, you have all of the features we've demonstrated today in your own hands, looking today at abnormal pulmonary veno-atrial connections.
Amazing session as usual, and the comments on the chat today are very great. Even during the presentation, we have already very nice comments. Thank you guys for that. So very good. I've learned a lot. And even though we had not a lot of images from Justin, the one of the infracardiac drainage was very beautiful. I really like that. Anyway, let's start with Dr. Norman Silverman with his comments as usual. And let's see what he has to add to this amazing presentation.
Well, that's actually a tall order, because I think it was such an outstanding session. And I think the physiology and the developmental way of classifying this makes the understanding of this whole entity very easy to understand. And I think that from my point of view, as I look at this, we have previously talked about echocardiography in this group. And I'm sure Justin would agree with me that many of the sick neonates are too sick and too young for a good MRI or CT scanning. And so they can go to surgery directly on the echocardiographic diagnosis of anomalous veins. Indeed, Dr. Marshall Jacobs has published a paper which has recognized fetal diagnosis of anomalous pulmonary venous return, and from the delivery room straight to the operating room to correct the obstruction in total anomalous pulmonary venous return. Now, Bob is a student of history, and of course, we didn't mention the person who described the scimitar syndrome, and that was Dr. Catherine Neal, who with me in 1982 were Bob's fellows in his laboratory in London. So I think that we have to acknowledge Catherine Neal, a very great lady, and describe this entity quite beautifully. But I want to say one other thing about this issue, which Bob hasn't talked about, which I'm sure he will expand on when I've asked him this question, is what about the arterial drainage, arterial supply in scimitar syndrome? Because I think this is a variable and important issue. The pulmonary artery may be extralobally sequestrated, so that you may have an arterial supply to the scimitar venous drainage that can be actually embolized from now with the interventional technique. In the old days was done by surgical ligation, and the specimen I have of scimitar syndrome, the surgeon actually worked a little too close to the celiac artery from which this anomalous vessel arose and infarcted the liver, whereupon the patient died. So I think that, Bob, I would like to ask you about arterial drainage in scimitar syndrome.
Well, indeed, Norman, I think you might have been having a senior moment at the time that we were demonstrating that, because I did mention that all of that, and Diane beautifully showed in her specimen that the artery from the sequestrated lobe was extending infradiaphragmatically, and it had, as you say, it had the devices in that had now been put in. And it's interesting that you comment on that, because you remind us of the time you were with us in London. And you remember at that time in London, we also had a respiratory professor with us called John Warner. And John Warner had a young Australian fellow working with him called Barry Clements.
And Barry and John Warner wrote this excellent article on what they called the inosculation syndrome. And it was the lack of kissing. And they pointed out that there could be lack of kissing between the lobe and its bronchus and the pulmonary vein and the artery. And I think it's rather nice to think of that variation in terms of inosculation. And so the point you make is a very good one. And the bronchus can be sequestrated, as you say. The pulmonary vein is the key point, emphasized by Catherine, who, as you also say, was a lovely lady. It's interesting that Catherine went over in the formative years of pediatric cardiology to sit at the seat of Helen Taussig. And it was her intention to return to the United Kingdom. You'll remember that Catherine was the most ladylike British person you could wish to come across. And despite all the time that she spent in Baltimore, she never lost her wonderful English accent, and she never lost her wonderful English habits. And she was a delightful lady, as she described the scimitar syndrome. She had lots of other very important observations that she made. So a lovely lady, and it's nice that you remind me of that. But Diane did, in fact, show you the anomalous connection of that.
I must have been fiddling around pictures and I missed it.
You'll have to look at it again because she emphasized all the important points you made.
Great. It just shows you that the importance of having this on the Congenital Heart Academy website so that you can continue to learn.
Indeed. I mean, the point you made and the point that Grace made also, Diane, I send her my PowerPoint and she makes these wonderful videos, and I tend not to look at them because I want to be excited when I see what she produces on the day. And the only thing that we slipped up on today was when she showed the case of the ascending channel in the paravertebral gutter. She chose a heart, in fact, that had right isomerism. And the one that she showed also showed the vein going up the right paravertebral gutter. And that was an ascending channel having gone up directly. And that was the mirror image of what I had anticipated. But other than that, I mean, Diane's, and that was also a very beautiful demonstration, but her other demonstrations were quite spectacular. And they matched absolutely what I was showing. But I'm interested in what you said, Norman, about the computed tomography. And what Diane showed you beautifully in many of her hearts was that the individuals also had isomerism. And if you're doing isomerism, then presumably in those instances, you would like to get a CT.
Yeah. I must say that, that this has stimulated me perhaps as far as Grace is concerned to revisit the ultrasound findings of this and do this in the latter part of the year as well. Bob, there's a
question. In fact, one of the chat boxes was questioning how accurate you can be with your echocardiography, or should we now be looking towards CT? To me, CT is now the gold standard for living anatomy, and you can. Justin showed how beautifully you can see what's going on. How do you think that you can make the diagnosis 100% with echo?
I would say about 99.9 recurring percent. I don't want to be absolute in this, but 99.9 recurring. And I think in our institutions, many, almost all of the patients have gone directly to surgery for this repair. Of course, there is a lot of complexity, and of course, right isomerism is the complex lesion. And of course, in that situation, I mean, there's so much other stuff that a variety of diagnostic tests are really important. I don't want to eschew even the use of cardiac catheterization for hemodynamic evaluation, etc. So yes, that's a very important issue. But I think echocardiographically, a large part of these diagnostic studies can be well achieved by using cardiac ultrasound alone.
Maybe we should ask Adrian what he would like to know before the patient ends up in the operating room. Adrian, what?
Thank you, and thank you for a wonderful presentation. And the specimens are really, really extraordinary. I think unless you see all the pulmonary veins and you are very sure where they go, so the connection and the drainage, we have a very low threshold to ask for cross-sectional imaging. And we've been surprised to see some cases where we thought they would be operable, and then on the CT, the pulmonary veins were very, very atretic, very stenotic, very hypoplastic for long extents. So the images that, for example, Diane showed us with dilated pulmonary veins beyond the place of obstructions, those are very favorable signs for us because we can work with that tissue. And it shows that that tissue, there is capacitance there. But you can be caught out in other difficult situations where there is intrinsic pulmonary vein stenosis associated with a total anomalous pulmonary venous connection. So it's not iatrogenic, it's not after surgery, but it's intrinsic. We know that happens in 20% of the cases. And it's better if you know that before touching the patient, because not even a sutureless, a so-called sutureless repair will help you in those cases.
So Adrian, what nowadays in Birmingham, would you be sending all of these patients for CT, or would you still be happy to do it on echo alone?
Not all of them. But if we have even a mild suspicion on echo that we can't see all the pulmonary veins and we can't see all the ascending or descending channels, so we have to follow all of them where they go. In that case, we might be willing to go to surgery without further imaging. But I would say our threshold is getting lower and lower to get CT imaging. And we've had recently a case like this where the pulmonary veins looked reasonable on echo, but when we did the CT, they were extensively hypoplastic, so we didn't do the surgery eventually.
What about Norman's point about CT potentially being a problem in a sick neonate?
Sorry, I lost the connection.
Norman made the point that if you have a sick neonate, you might be concerned about taking a sick neonate to the CT room and the potential problem of obtaining a CT.
Of course, it's always a balance, but we can get CT very quickly nowadays.
But you still have to transport the patient from the nursery down there, and this is certainly a risk. I know everything we do, we take care of, but you have these kids, you have to take them on a ventilator. The ventilator has got to go into the CT room, not like a magnet, of course. If you're going into a magnet, you've got an even greater problem, because everything has to be non-metallic in order that you don't jam the respirator into the magnet and spoil everything. It's happened in Yale, interestingly enough. I think that there is a little interest, the risk is there. And of course, obviously, everything is a clinical balance. And if it looks really like the veins are fat and you can trace them all, I would still say that I would be happy. And of course, it's the surgeon that's going to be left with holding the baby, regardless of what I say. But I would be happy to have a competent surgeon do the veins if I could see all the veins draining as we usually can.
One little thing on the scimitar. We know that there is an association with this syndrome where the heart is not always in the left chest, as we call it. So I would say if we see that the heart is in the center or more to the right, let's call it dextrocardia.
Yes, I think that's a great point, Adrian. I think that mesocardia is a very common feature in scimitar syndrome, and it's related to right lung hyperplasia with the shift of the mediastinum over. And I would say that in my experience, the commonest cause of mesocardia is scimitar syndrome. So whenever you find a heart in the midline or slightly to the right and you're worried about it, think scimitar, and you can usually get to the diagnosis that way. Obviously, There are other causes of the heart shifting to the right, but that's certainly, I think, a clinical red herring. When you find that the heart is in the right chest, beware of the scimitar syndrome.
Yeah.
Adrian, in the build-up, when we were preparing the presentation, you had a whole series of questions that were very sensible. I thought that I had answered most of them in my narration, but do you have any that we didn't answer?
Just a practical, probably a practical and a more theoretical one. Do you use the term return in any circumstance now for total anomalous or partial anomalous?
That's a good question. I think I would rather talk about connection and distinguish that from drainage. So my own preference now would be to talk totally or partially anomalous pulmonary venous connection, because I think that is the key term, because as we discussed, the drainage can be anomalous whilst the connection is normal.
Okay.
So my preference would be to use connection now, but return, as you say, return can be anywhere.
So, and then also be theoretical, in a left atrial isomerism with bilateral pulmonary veins connecting to this, to each atrium, 2 and 2, would you call these normal connections and mixed drainage, or how would you call this theoretically?
I would call that isomeric atrial connection in the setting of left isomerism. So not only is there isomerism of the left atrial appendages, there's isomerism of the pulmonary veins. I think that is the perfect example where we have isomerism. I think, as we also discussed, I think in the setting of right isomerism, for example, and Diane showed you an exquisite, the case that Diane showed of that heart with the lungs, with the pulmonary veins coming back to the lungs, where she showed you bilateral superior cable veins, bilateral terminal crests. That's the most beautiful example I've seen, where almost there you had 2 right atrial chambers, and then with a confluent venous sinus that also received the pulmonary veins. I think that was an exquisite case. And the other interesting case there was she showed you that there was isomerism of the right appendages, but there was isomerism of the left bronchuses. And it's no problem when you describe what's going on. I think that's right. Beautiful.
I think that there's another thing about that case, Bob, that struck me as very unusual, because in right isomerism, the venous drainage is either vertical, usually, or infradiaphragmatic. And this example that Diane showed was actually a rocking case, because the veins drain to a coronary sinus. And that is extremely rare in right isomerism.
It was to a systemic venous sinus rather than a coronary sinus.
Okay.
But it was
unusual.
I mean, the one she showed you with the coming to the coronary sinus was in fact a usual atrial arrangement.
Ah, okay.
The interesting thing though is the isomerism of the left atrial appendages. The lateral pulmonary venous drainage to each of the atriums in that case looked very much like the case that I showed with isomerism of the right atrial appendages, but with morphologically left bronchuses. Sure. So does the lateralization of the pulmonary veins in that right isomerism case follow more with the bronchial anatomy?
It's a very interesting point. I mean, that is the thing. I mean, it's only when we start describing things as you did that we will begin to see. I mean, you asked the right questions and you showed us what was going on unequivocally. There was isomerism of the right atrial appendages. You showed us the bilateral terminal crests. By the same token, unequivocally, there was left bronchial isomerism. So a very interesting point you raised there, that perhaps the bronchial isomerism was driving the pulmonary veins to come into the back of the heart, as you showed. Very interesting case.
I think that's the only case I've ever seen with the bronchial anatomy not matching the atrial anatomy.
Indeed, indeed. And it's one of the few cases, usually, as you know, when you have cardiac connection in the setting of right isomerism. The pulmonary veins come together and they form a midline confluence, whereas in your case, they were spread out. Yeah. Now, Norman, you will remember that you say you have several examples of direct cardiac connection with usual atrial arrangement. Do you still have those cases?
I still have them, Bob, and they're real, and they're up in our chapter on the web on this very entity. I could not find an autopsy example, and I think that the surgeon that did the case that I put in our presentation said, look, he opened the atrium, he said he saw the pulmonary veins were in an unusual position, and all he did was he removed the patch to the left, to the right of the pulmonary veins, so that the pulmonary veins then drained through an atrial connection into the right mitral valve. So it was a simple operation, and I wonder if Adrian is still here, whether he could make a comment about this, that he's ever seen this surgically.
Adrian, are you still with us? Looks as though he might have lost his connection.
Yeah, he was having trouble with his connection.
So Grace, do you have any comments?
Yeah, I have some questions on the Q&A chat box. If we can go through that, only two for now. So one is from Muna. She's asking, is it possible to see anomalous left pulmonary veins passing behind the left atrium and the drainage directly in the right side of the superior vena cava?
To an extent, that's what I showed in my case, where there was a horizontal channel. And that's the one, that's what's being called the meandering, or the meandering pulmonary vein. So the guy who has the biggest experience of totally anomalous pulmonary venous connection that I know is Ujjwal Chowdhury from the Old India Institute of Medical Studies. And he's described several variants of that, where the veins cross underneath the heart, and then they come up in the left paravertebral gutter.
Okay,
echocardiographically, can I just say something, Grace?
Yes, sure.
Echocardiographically, this is not an uncommon finding when you see anomalous pulmonary veins. Upper pulmonary veins, they look like they're draining to the left atrium, but they actually have this membranous structure, which is the atrial roof between them, and then they drain into the right atrium.
And they cross over, don't they, underneath the heart?
Yes.
Because, I mean, we've talked about, I mean, the typical case where it goes up and then across through the brachiocephalic vein, that's called the snowman. And I think the one where it goes underneath, I'd call that the underarm snowman. Exactly, exactly.
Adrian, you're back. Did you hear?
Yes, sorry, I got an urgent call, so I couldn't follow.
Okay, so we asked if you've ever seen totally anomalous pulmonary venous return to the right atrium without the setting of isomerism.
Personally, no, but I've heard that there is at least one description in the literature, but I haven't seen it myself, no. Okay,
I put mine, my case is up on our website, but it's very difficult to find any autopsy information. Diane didn't have any cases, and I asked for several other archivists if they've had it, and I've not received any specimens from them.
And what was going into the morphological left atrium in this case?
Nothing.
Not the veins. The veins went to the right atrium, but on opening the atrial chamber to do the repair of this so-called atrial septal defect, all the surgeon needed to do was take a piece of pericardium and connect it to the right side of the pulmonary veins and baffle that towards the mitral valve. And so it looks like an ASD repair, an atrial septal defect repair.
And I haven't seen that. I know it was your case. Were the pulmonary veins close to the interatrial septum onto the right side?
They were to the right side.
Because this links to a question that I had about the so-called malaligned interatrial septum. And it's been discussed a bit in the context of hypoplast left heart. But my question is this malaligned atrial septum, where people would consider the pulmonary veins in a hypoplast that actually they don't, they are connected normally but drain anomalously because of this insertion. But my question is, how do we then define the intraatrial septum as being part of the definition of the atrium?
Indeed, and I mean, and in a way, Adrian, that those describing this alleged malalignment of the atrial septum, to my mind, it's not necessarily the atrial septum that's malaligned. I think it's a divided left atrium, and it's the shelf that's dividing the left atrium, with the pulmonary veins then connecting through an atrial septal defect into the right atrium.
Yes, because
there's a discussion, in fact, in a recent issue of Cardiology in the Young, where we've written an extensive commentary on this very constellation of lesions. And it all depends, as you say, on how you define the atrial septum, because the atrial septum, another question you asked me in our discussions, is the formation of the septum independent from the migration of the pulmonary veins to the roof of the atrium? And of course it is. And in fact, you don't get the superior interatrial fold formed, as Diane showed you, until the pulmonary veins reach the atrial roof.
Mm-hmm.
So how can the septum then be malaligned when the superior interatrial fold depends on the pulmonary veins reaching the atrial roof? The flap valve can be malaligned, and in hyperplastic left heart syndrome, it's the flap valve, the primary septum, that is malaligned, but the superior interatrial fold can't be malaligned.
That's right.
So that means that you can track the initial opening of the pulmonary vein that is close to the atrioventricular junction. You can track it during development or up to when all the pulmonary veins come.
Correct. We wrote a paper a long time ago on that. We had a very nice American fellow who came with us called Nauth, Alison. She's now working, I think, in Boston. And she did an extensive study on the development of the pulmonary veins. And we showed that a long time ago. That's also published in Cardiology in the Young.
Yeah, I thought that your editorial was very skillful in that set, Bob, including the fact of the advantage of peer review in terms of making things better.
Well, I'm glad you picked up on that, Norman.
But yes, I did very well. But the problem, I don't have senior moments all the time, Bob.
Join the club, Norm.
But I
part
think
of the time, whilst we only have them part of the time, we're all right.
That's correct. But the issue here about these veins is perhaps this isn't an entity. I mean, maybe it's a false description of what we see. And again, now, of course, once you have people publishing in the literature about the malalignment of the septum, you see this. I think I agree with you that it's a septum primum, or the primary septum, that is deviated. And the veins are, as you would expect.
Indeed, yes.
But you can.
That's an important point.
You can expect that because we talk about the malalignment of the outlet septum on the ventricular side, so people can easily make, a parallel shift into talking about that on the atrial septum.
Indeed, oh, indeed. But it all depends on the quality, on the definitions you're using for the different structures.
Okay, we have one last question. And Jason is asking, are there examples of very fine tributaries to the ascending channel rather than a proper formed pulmonary vein?
It's a good question, and I noticed that one. I've never seen that. I mean, there is marked variation in the way that the confluence is formed. And I mean, and Diane showed very beautifully confluences that look like Christmas trees, and you have upside down Christmas trees. And I guess, I mean, the point that Adrian made, that if the pulmonary veins themselves are stenotic and hypoplastic, then that could give the situation you described, Adrian, that you'd been picking this up with your CT. Perhaps you've seen the situation with fine channels. I've not seen it in an autopsy.
Not completely, not diffusely, not bilateral. Probably those patients will not survive. But we've seen it onto the one lung, for example, where there is a leash of vessels. There is no individualized pulmonary vein, but it's a leashed, a very small vein.
And I think that we're going to see this more and more. I mean, the point that Grace made, I think that the beauty of CT now is it shows the anatomy living. I mean, Diane does the most wonderful dissections, but when you see it for real and you don't have to dissect it, it's so much easier to look at. It's so much easier to see what's going on.
Yeah. One question that I don't know whether you touched on was in cyanotic patients or in functional ventricular heart patients, when they develop connections between the pulmonary veins and either the systemic veins or the pulmonary arteries, these malformations, veno-venous or veno-arterial malformation, are they do they exist there embryologically, you think, or are they de novo formations?
I think they are there from the outset, and then so normally I think as the pulmonary veins develop within the lung, they have both connections to the systemic channels and they have a connection to the pulmonary vein, and I think that they retain the systemic connections as if they lose the connection to the pulmonary vein, then they retain the systemic connections. I think the same goes with systemic to pulmonary collateral arteries. I think they are there from the outset with the potential, almost a safety valve, if you will.
Thank you.
I wonder whether you would let me share my screen with you and show you this patient with the total veins to the right atrium.
Grace is in charge.
Yeah, please, Norman, do that.
Okay, let's see if I can do this. Okay, so here is straight out of the chapter is the diagram, because I couldn't find a specimen, but here is the echocardiogram here, and you can see here there are the veins scooting around the back of the atrium. There's the left atrium, and the other argument that this is not an atrial septal defect is that there's a right to left shunt across the atrial septum. Let me see if I can stop that. And I'll show you that there's actually at atrial level here, there's the pulmonary arteries, then pulmonary veins coming around the back of the atrium. And then here is the right to left shunt coming across the atrium. Here's the left atrium with the left atrial appendage. Here's the mitral annulus here. Here's the rest of the atrial septum. And you can see that the shunt across this little atrial communication is coming this way into the left atrium. So this has to be an anomalous pulmonary venous return. I'll let that play again for you. And in fact, we also looked at the heart in the sagittal plane, opposite to the coronal plane that we showed here. And you can see the pulmonary veins are draining to the back of the atrium here. I'll just let that go into play in a moment. There you go.
There's no reason why it can't happen, no.
Sorry?
There's no reason why it can't happen. I mean, if it can happen. No. I mean, that case that Diane showed us where the pulmonary veins were joining into a systemic venous sinus, you've got the same situation here, haven't you?
Right.
But
well, anyway, thank you very much. I'll let that off now, and thank you for letting me show you that.
It's just that you would agree that this is not the entrance of individual veins clearly onto the roof of the right atrium. It's it would be nice to have the specimen.
This, unfortunately, the patient is alive with a patch. You know, which is maybe a better outcome.
Indeed.
We are patient, Norman.
Thanks God he's alive. Good news.
Well, thank you very much, Grace. It was an excellent session today, and
it was amazing. It was really nice.
So for our final session of this third trimester, this second, what is it? What did you call it? The second semester. We're going to do
second trimester. Yes.
we will describe the sinus venosus defect, and as you say, we will discuss where we go for our third semester.
Well, that's
it's going to be amazing. It's going really going to be nice.
How about you, Talmina?
We should get Grace to organize Have Us All in Qatar.
That's right. That would be
lovely.
great.
Let's do that.
Well, get
Let's
all
do
the
that.
money, Grace. We'll have a meeting in Qatar. You can take us to the beach.
Oh,
We could have the meeting on the beach.
no, we can go to the desert. Much better here than the beach. The beach is not, it's nothing much, but the desert is amazing. It's very beautiful.
We know there's lots of money in Qatar, Grace. You need to set it up so we can all have a meeting in Qatar.
Sorry, do you want to take the last question? Because I think it comes up often. From Salim.
Is there one more question? I haven't
Yes,
seen.
from Salim Ahmad. He's asking about coronary.
It's on the chat. It's on the chat. Yes.
Take it.
Okay, my question is about coronary venous sinus, which is usually considered left atrial structure. What is its fate in isomeric states, right and left?
Well, we know, in fact, that the coronary sinus is the left sinus horn. And if you have right isomerism, then you do not have a coronary sinus. You never have a coronary sinus in the setting of right isomerism. In left isomerism, paradoxically, both of the superior cable veins are trying to be the coronary sinus. So in some of the heart, and as the more we look at them, you can see the way that the cable veins enter the atrial chambers in the setting of left isomerism. They are more and more looking like coronary sinuses, but you couldn't have two coronary sinuses because if you did, they'd meet together and the blood would go around in a circle. So in left isomerism, they're trying to be coronary sinuses. In right isomerism, you never have a coronary sinus.
Okay, sounds good. Good question. Okay, guys, so see you in 1 month. I'm sure it's going to be another amazing session. Thank you very much. Thank you very much for everybody who attended today. Bye-bye, guys.
Thanks, everybody. Great session. Bye-bye.
Cheers.
Bye-bye.